Hi, Carissa here again with Southern Homegrown. And in today's video, I wanted to talk to you a little bit about, oh no, my water just broke. Or did it? Well, yeah, usually for most of the time, it's not like on TV where there's this huge gush and everything is soaked. Usually most of the time, it's like a little trinkle and you're kind of like between the fact, is that urine? Or is that my water broke? You know, so you kind of think about it. And then like 10% of women, you know, before their labor starts, you know, this is pretty much what happens. You know, you got that little trinkle and you're not really 100% sure. But there's a few tests that you can do and a few things and questions you need to ask yourself to determine, is this really my water broke? So first of all, you want to ask yourself, what color is the fluid? Because hopefully it's clear. Because if it's not clear, if it's a yellow, brown, or green color, that could mean the presence of meconium, which, you know, could indicate that the baby had passed meconium, that the baby may be in distress, but not necessarily. It may not mean that. You know, you never really know, not always. So, you know, the fluid may also be red or like pink tinged. But you want to notify your care provider as soon as you see that the fluid is not clear. You definitely want to let them know what's going on. And you can also definitely need to just let them know your water may have broke. You want to notice the odor. Make sure there's no foul odor, because most of the time amniotic fluid is going to have a salty, sweet like smell to it, like an earthy kind of smell. It's not going to stink or smell like infection or anything like that, you know. And you want to notice how much fluid there was. So you may think, how do I do that? But you know, you can kind of estimate it, like a half a cup, something like that, so that you know how much of the fluid has actually been going. Then so you can tell your care provider. And there's generally a few tests that they can do to tell if this is truly your amniotic fluid and not urine. They have something called nitrazine paper or a nitrazine coated swab, and you can put this in it, and because the normal vaginal pH is more acidic, whereas the amniotic fluid is more alkaline. So this strip and this test will be able to tell the difference between that. So if the membranes is ruptured, then the swab will turn a really dark blue or a green, almost black color. So then that's the way you know, yeah, this is amniotic fluid. So you want to observe the presence of meconium or vernix in the fluid, if at all possible. I mean, it depends on how much you have coming out. But there is possible risk that can come with you know, the rupture of your membranes. As you know, this is the protective sac that the baby's in. This keeps from any bacteria or anything being presented to the baby. So if this is truly your water has broke before your actual labor starts, there's a few precautions you may want to take. Don't get sit-down baths. Don't present anything into the vagina. You don't want to contaminate anything. Just kind of let it be. Let it run its course. But then there's also a great, it's more extreme and kind of rare, but you also have the risk of something called a cord prolapse. And we had mentioned that earlier in one of our other videos, but I'm going to explain it a little more in detail here. Whereas a cord prolapse is when part of the umbilical cord slips out past the baby and like out of the uterus. It may not be exactly all the way out of the vagina, but you'll feel something in the vagina, and it'll be the cord. So, you know, this in this case is a pretty life-threatening emergency, because the baby's head could compress the cord, and which would cut off oxygen flow to the baby's brain. So in this case, if this occurred, you want to maybe take the following steps to try to help with this process until you can get to the hospital. This is definitely a transfer situation in my book. You would place mom in what is called knee chest position, which is going to be when the mom's chest is on the ground and her butt is up in the air like this. So mom's chest is going to be on the ground, booty's going to be up in the air. So then someone is going to need to call 911 and inform them of what's going on, while someone's going to need to place the cord back into the vagina and keep it moist and warm. And you're going to want to keep the baby off of the cord. So you're going to hold the baby's head up off the cord by walking your hand up the cord from the baby, like up the cord to the cervix, and gently press the baby up, you know, so like you're going to move the baby up. You're going to be gentle with it, but you're going to apply enough pressure to keep the baby's head off of that cord so that it can get a good oxygen blood supply. It's going to be harder to do during contractions, but it's very important to keep the baby's head off of that cord. Don't remove your hand. Even during transfer to the hospital, you do not want to remove your hand. You want to make sure there's blood flow through that cord and that is not being compressed until they are able to deliver the baby, you know, more than likely by C-section. This is one of those times that we're grateful for our OBs who are surgeons and perform C-sections. So, and like we said, with the risk of, with ruptured membranes, there's always the risk of infection, of course. You want to prevent any germs or anything from entering, like we said, with, you know, for the membranes that are ruptured and it's prolonged that way, you want to make sure to keep hydrated, because this fluid, as it is leaking out, even if it is slowly leaking out, it is still replenishing itself. So you're okay. It's still not like it's going to be like, oh, wait, no, you know, it's going to keep replenishing itself. So you need to make sure to stay hydrated. Another thing that you may want to think about, the different, you know, I may talk about in this video, is the different reasons for transfer. Say if you have home birth or a birth center birth, you know, the different reasons for transport might include fetal distress, and this is going to be indicated by abnormal heart tones. So say we're monitoring the baby's heart rate doesn't come back up, or, you know, it stays low for too long, it's not rebounding, you know, this may be an issue that we need to deal with and we may need to transfer. Another one would be moderate to thick meconium staining in the amniotic fluid, combined with non-reassuring fetal heart tones, you know, so that's a pretty good sign. Like we said, one without the other, but those two together pretty much kind of says, okay, yeah, this baby is in distress. We might need to do something. We need to go ahead and transfer. Interpartum bleeding or hemorrhage, when mama's bleeding really good, you know, really heavy, this may be another reason to transport. Any non-vertex presentation of the baby, such as breech with an unproven pelvis, you know. There is states that will allow midwives to deliver breeches, and this can be done at home, but with an unproven pelvis, unless you have an experienced midwife, this could be an issue that you would need to transport for. Twins with baby A not in a longitudinal lie, twins with A in a non-vertex position with an unproven pelvis. Like I said, and there's some states that you can deliver twins at home or at a birth center. But with an unproven pelvis, you would need a very experienced care provider, or you would need to transfer. Blood pressure greater than 140/90 on consecutive readings. So means, you know, that blood pressure's going up and it's not coming down. You know, there's something going on, we might need to transfer. Maternal fever, you know, on consecutive readings, like say, yeah, you may have a little fever, you may get hot from the water, or, you know, the strain of labor, you know, you may get warm, but if this reading is not going down and this reading is actually rising, that could be a possible sign of infection, and it might be a reason to transport. Ruptured membranes without the onset of labor for more than 96 hours. So at this point, you might be kind of pushing it. It depends on the midwife and the circumstances, but most of the time at this point is when transfer will occur. Signs of infection with the prolonged rupture of membrane. Say you start running a fever and aching and things after your membranes has been ruptured for a while. You know, this could be a sign to transfer. It could be a sign of infection. lack of reasonable progress once a good labor pattern has been established. So, and especially like with first-time moms, you know, they may get tired and, you know, they may request transfer or, you know, something like that. So, I mean, you know, that's kind of one of those things. It's a case-by-case basis and depends on the care provider and things, but, you know, can definitely be a reason to transfer. Like we said, maternal request for pain medication. You know, mom's just like, I'm done. Let's transfer. I'm through. I'm done. I'm wore out. I can't do this anymore. So, of course, in that case, you know, we want to make sure that she is done and that she's not just in transition, you know, but, you know, mom says mom's done, you know, we need to make sure, and then if mom's done, we'll transfer. Patient request to go to the hospital, same. Any other medical or obstetrical condition that warrants immediate hospital transfer as determined by the care provider exercising ordinary skills and judgment. You know, so most care providers, midwives are trained in emergency, you know, emergencies, and they know, they're well educated on when to transfer, and they have a good grasp on that, and they're there to let you do as you need to, but yet to still be safe with it. So, you know, they're there for you. But like we said, if you have any questions or comments or anything, you know the drill. southernhomegrown.com, comment section, send us a comment, or email info@southernhomegrown.com. Thanks. Have a great day.